Welcome to the Well-Being Manifesto podcast, where we translate science and experience into realistic and sustainable ways of living. In each episode, we offer clear and practical strategies to support all aspects of well-being that matter to you, whether in your home, your community, or place of work. The Well-Being Manifesto is hosted by Dr. Moain Dabrh and Dr. David Freeman, who have spent their careers advancing whole person care. Join us as we focus on real lives and real change, with less hype, more truth, better living.
Hello, everyone. Welcome, one and all, to a new day and a new episode on the Well-Being Manifesto podcast. I am Moain Dabrh.
And I'm Dave Freeman. Today's guest is Professor Barry Franklin, a cardiovascular and clinical exercise physiologist and pioneer in cardiovascular disease prevention research. His decades of experience and work have helped define the dose of physical activity that maximizes health span and lifespan. He served in many leadership roles, including the past president of the AACVPR. And in our conversation today, we'll explore how movement becomes medicine, how balance intensity with safety, and how to cut through the noise of fitness myths. Professor Franklin, welcome to the Well-Being Manifesto podcast. We are delighted to have you.
Thanks so much, Dave.
So before all the accolades and publications and decades of research, could you comment what early life experiences helped shape your passion for exercise safety and cardiac rehabilitation?
Sure. Thank you. As a kid, I was born and raised in Cleveland, Ohio. As a kid, I have to share with you guys, I was very, very interested in judo and karate and got up to the second highest belt in judo at the age of 10 or 11 years of age. As a teen, I really got interested in health, fitness, even bodybuilding competition for several years. And then in high school, I got involved in fitness testing. Pull-ups, sit-ups. I wanted to be the top in high school. I also took on gymnastics, primarily still rings. I was able in high school to do an iron cross, which I'm still proud of to this day. In undergraduate school, I went to Kent State University. My major was health, physical education. I also competed in gymnastics for 4 years there. At Kent State, I met two fabulous professors, Dr. Lawrence Golding, Paul Ribisu, who really turned me on to the field of exercise physiology, exercise science. As a gymnast, they had Franklin, they dunked me underwater to determine body density and relative body fatness. I wore a mask and had my VO2 max determined. They could estimate cardiac output. It was a really neat thing. And I said, you know what, I'm going to go on and continue my education. I went on to the University of Michigan, where I got a master's degree in exercise science. I joined the American College of Sports Medicine in 1970 at my advisor's recommendation. I'm a member 55 years now. I was president of ACSM in 2000. Then I joined several other groups, the AACVPR, the American Heart Association, and more recently, the American Society for Preventive Cardiology. And I came to the sobering realization that these associations, being a member, opened up unimagined doors and opportunities for me, getting to know the presidents and some of the people there. I then went on to Penn State University. I worked with two giants in the field, Dr. Ellsworth Busker, Carl Stadefalk, who wrote the first ACSM guidelines book. And then I went into medicine, and I've been working with cardiologists ever since 1975, 1976. One really quick story, when I was an undergraduate, I met with a very famous cardiologist near Kent State who spoke at our place. His name was Herman Hellerstein. When I grew up, there were two big cardiologists, Hellerstein and Bob Bruce, who developed the Bruce treadmill protocol. And I went into Hellerstein's office one day, and they said, you have an appointment? The secretary said, no. And she said, well, you can't see the great and powerful Oz without an appointment. So I started walking out, and long story short, I run into this guy. He said, what are you here for? I said, I'm looking for some career advice. And he said, come into my office. Dave Moain, he spent an hour with me that day, didn't even know me. And that meeting changed my life. Ironically, 8 years later, after I got a PhD, I worked with Hellerstein for 5-6 years. And what he told me at that meeting is, Franklin, if you want to do something with your life, you got to get an MD, a DO, or a PhD, which I did at Penn State. Got a call from Hellerstein's office, and the rest is history. I worked with him, Nanette Wenger, John Naughton on the National Exercise and Heart Disease Project in the mid-1970s. So that's my background.
Oh, I love the power of impact from people who just can have one conversation that can change your life, and how thoughtful of him to spend that time with you and give you that. So, Professor, you've studied thousands of patients across all fitness levels. When it comes to health benefits, what is the smallest effective, quote unquote, dose of exercise, amount of exercise? And how little is enough to make a real difference? Because often people hear, oh, just walking for a few minutes can be good for your health, and they would discount that. So can you tell us a little bit more about that?
It's an excellent question, a question I regularly get. So I sat down and put a few notes down. First of all, I want to open up this response with two very famous quotes that I think you guys will like. Walter Bort said, "We live too short and we die too long." It got my attention as an anti-aging specialist. Another guy who I got to know, he wasn't really a mentor, but we interacted with a great deal, a guy by the name of Ralph Paffenberger. Ralph Paffenberger is the only professor I know that ever had two offices, one at Harvard and one at Stanford. And Ralph Paffenberger, an epidemiologist, said everything that worsens with age gets better with exercise. And in so many respects, he was so correct. To get back to your question, how much exercise is enough? For many years, I said you need, according to the early literature, at least 10-minute bouts of exercise. I was wrong. Over the last decade, studies using a beautiful technology called accelerometry have determined that bouts of exercise, listen carefully, 1 minute or longer, if repeated throughout the day, can confer significant health benefits. What else did I learn? Climbing stairs. A number of studies have shown, in a nutshell, you climb 5 or more flights of stairs most days of the week, it's going to lower your risk for atherosclerotic cardiovascular disease and mortality. Blockbuster study last year in Europe, I don't know if it's been published yet, showed regular stair climbers have a 30-35% lower mortality than their sedentary counterparts. How about steps per day? You guys and I know we've been saying 10,000 steps a day for many, many years. That's wrong. The more recent studies in Lancet and some of the top medical journals in the world said that traditional recommendation should now be replaced 7,000 to 8,000 steps per day. That's regardless of age or sex. 7,000 to 8,000 steps per day. You get nearly all the benefits as 10,000 steps. What's also fascinating is that if you're sedentary, if I see a patient in the office, he's sedentary, I don't tell him 7,000 to 8,000 because there are new studies showing if you're sedentary and you embark on just 2,500 to 3,000 steps a day, you're going to get significant benefits. So 10,000 is a bit misleading. It all depends on the people. What else did I learn? Walking speed is a very strong prognostic indicator. I tell our fellows and residents, you're talking about vital signs. One of the best vital signs you can get is look how fast that patient walks out of your office at the end of your visit. Because if he walks out at a mile an hour, he's heading in the wrong direction. It's as simple as that. Take-home message is new studies have shown if the older people walk less than 2 miles an hour usual pace, that's the poorest prognosis. Over 3 miles an hour, which is over 3 METs, metabolic equivalents, it's the best overall prognosis. Sometimes I'll tell patients you ought to walk at 3 miles an hour. And sometimes the patient says, I'm 85, 3 miles an hour, a little fast for me, Dr. Franklin. And I'll say, okay, let's start at 2 miles an hour, start on the level and gradually increase to 3.5% grade. 2 miles an hour, 3.5% grade is also 3.4 METs. Lastly, outdoor cycling. When people say, what's a good starting dosage that'll improve me? You want to work, once again, 3 to 4 METs. That's about 6 miles per hour, a slow pace for outdoor cycling. So I think the take-home message is, as I've just shared with you guys all this stuff, you can disguise your exercise by taking more steps, by walking at a faster pace, as opposed to you got to run to the gym every day and do those kinds of things. So that's kind of the latest. To answer your question, what's minimum?
No small is too small.
Yeah.
For when it comes to exercising.
Yeah.
And I like that what you said, which is you start small, you build towards what you would like to eventually achieve. And that's also what can be a barrier for people who are trying to enact healthier habits, is that they think it's this all or nothing mentality.
I agree 100% with you. In fact, I oftentimes when I see people and they say, "Doc, what should I weigh?" And I say, "What's your current weight?" And it's 300 pounds. I don't look at a table and say you need to weigh 165 pounds to get into terms of an ideal weight. Blackburn and others have shown a 5% weight loss confers very significant health benefits. So if I got that 300-pound guy in front of me, I'm going to say, and I'll ask him, what do you think you could get to? But after, I'll tell him, in my humble opinion, if you reduce 300 pounds by just 15 pounds, get to 285 or less, you're heading in the right direction. I think the guidelines, as you well know, sometimes are pie in the sky, but they discourage the heck out of patients. So I want to overcome inertia, to your point, and give them the smallest effective dose that's realistic. And in this case, it's 5% for people who are very heavy. That's not the ultimate goal, but 5% is the initial goal. And most people will say, I can do 285. And I say, why? Because they said to me, well, a year and a half ago, I was 275. Now I'm 300. So little things like that are important, which they don't teach you in medical school, by the way, or in college. Little pearls like that are important in counseling patients.
That's why we encourage coaching skills for medical students. So.
Yeah.
Yeah, I love this because it's powerful. Even a 5%, it gives people, it's like a positive psychology because, and it ties into this next question about there's these fitness buzzwords that are bound, like VO2 max, aerobic, anaerobic overload. For the everyday person who just wants to move and live better, what are a few key metrics, Dr. Franklin, or principles you wish everyone understood?
As I saw this question, as you gave me a heads up on this question, I put 3 specific terms down. The first and foremost is cardiorespiratory fitness. You hear that all the time. By the way, that's synonymous with VO2 max, maximal oxygen consumption, maximal oxygen intake, aerobic capacity. They all mean the same thing. It's the maximum amount of oxygen your body can take in and supply it to muscles and tissues to produce energy for muscle contraction. Ideally, you can improve that by moderate to vigorous exercise on a regular basis, most days of the week, even 20 or 30 minutes. When people sometimes say, how often? I go to a very famous quote. You guys may know the name Joseph Alpert. Joe is the editor-in-chief of the American Journal of Medicine. And he did a beautiful editorial one time because people ask him all the time as a physician, how many days should I exercise? And Alpert said, only on the days you eat. That seems to get the message across. And I think he was very, very correct. Fitness, which we're talking about, is quantified in terms of what we call metabolic equivalence, or METs, which we'll talk about a little more later. But the major point I want to make is less than 5 METs, which means you can't finish stage 1 of the Bruce treadmill protocol, 1.7 miles an hour, 10% grade. Less than 5 METs, poor prognosis. Greater than 10 METs, which is stage 3 of the Bruce protocol, 3.4 miles an hour, 14% grade. You can do that. You generally do very well, even if you got coronary artery disease. That's an excellent prognosis. In general, the higher the MET capacity via treadmill testing, the better your survival. What are METs? Once again, units of energy expenditure. Sitting here at rest, the 3 of us are at 1 MET. If you go out and walk at 3 miles an hour, you're working at 3.4 METs. Moain, if you said to me, Barry, I want to play singles tennis, how many METs? It's roughly 6 to 7 METs. Jogging at 6 miles an hour is roughly 10 METs. So that's what you use. I'll share with you a fabulous equation because I get this question all the time. Patients say to me, Doc, how in the world can I guess how many METs I'm working at? A good friend of mine in Australia, John Wicks, not the actor, John Wicks, came up with a formula that we published and used in several papers. And the formula is very simple. It's 6 times the heart rate index minus 5. The heart rate index is the activity heart rate divided by the resting heart rate. Let me give you an example. Patient says to me, Doc, how many METs am I working at when I play singles tennis? And I said, what's your resting heart rate? He said, it's about 70. He said, what's your heart rate when you play singles tennis? He said, 135 to 145. I said, okay, let's say 140. 140 divided by the resting heart rate is what? 140 divided by 70 is 2. 2 times 6 is 12. Minus 5, 7. So I say you're working at around 7 mets. Very, very significant, important. Lastly, what are the types of physical activity? We generally say light activity, which is less than 3 mets. Moderate activity is 3 to 5.9 mets, like brisk walking or calisthenics. Vigorous activity is typically greater than or equal to 6 mets. You say, Barry, what is that? It's singles tennis, it's jogging, and so on and so forth. Rather than those met levels, however, I personally like the relative fitness. So relative fitness, if it's less than 40% of your capacity, Moain, it's light exercise. If it's 40 to 60% of your capacity, it's moderate exercise. And 60 to 85% of your capacity, it's vigorous exercise. So the point I'm making is, if I got a patient with a 5 met capacity and he's working at 3.2 mets, that's a little over 60%. That for that patient, that's vigorous physical activity. You see where I'm coming from? So looking at those relative as opposed to fixed mets is probably more accurate.
The quantity and the intensity.
Yes.
Yeah, and sort of a follow-up, what kind of advice would you give the non-specialist clinician to know or look for as a first-line screening point?
Screening point, I assume you guys are referring to exercise. Where do you start? I think the first and foremost message I would give you is, I don't care what the patient wants. In no instance do you start with vigorous exercise or high-intensity interval training day one if this guy's 40, 50, 60 years of age. That's point number one. Point number two, I'd emphasize, and I've been studying this stuff since my hair was black, so I know what I'm talking about. I'd emphasize if your patient's over 50, it's a very strong likelihood he or she's got underlying cardiovascular disease from studies that I've read from the Cleveland Clinic, as well as a recent study in Sweden. Second point that I'd make is be particularly cautious for your patients who've got a markedly abnormal risk factor profile, elevated coronary artery calcium score, or strong family history of coronary disease. And the last point I'd make in terms of screening is I would tell people, if you develop symptoms, even with light walking or moderate exercise, which is 3 mets or 4 mets, stop the exercise immediately, get a medical evaluation and clearance before resuming that exercise program. Safest recommendation you can come up with.
Mm-hmm. So you are warning against jumping into high intensity exercises and workouts because they can backfire, especially for those who have been sedentary for a while or not trained and conditioned enough to go into that. What is the best advice that you give to help people ease into movement and exercising safely and gradually? Maybe
I'll get to your question in a few seconds, but I want to preface my response because it'll give you a better idea as to where I'm coming from. My hesitation about recommending or starting a program with high intensity interval training for a guy in his late 30s, 40s, 50s, 60s stems from a case that I was asked to look at. I wasn't involved, I wasn't sued, a case that I was asked to look at a few years ago. And I agreed to do it. And it was only the second case in my life because I generally avoid wanting to get involved in these cases. But I looked at it. It was a 38-year-old male nurse, obese, body mass index 30, who wanted to get in shape very quickly. He had no history of heart disease or anything like that. He filled out all the forms saying, I have no heart disease. I've never been told I have heart disease. I've never been told I got high risk factors. I don't get just chest discomfort on exercise, etc. So he enrolled in, I won't mention the name, a high intensity interval training program. Got a heart rate, so on and so forth. I was able to view the film watching him that day because this place keeps a film of everything. During his first session, during high intensity interval training, his heart rates got up to as high as 150 to 180. You can imagine that's, if you estimated max heart rates, you're in the 90, 95% range, may have been even higher. During the last session, then, he was jogging on a treadmill, and I questioned day one, why in the world is he jogging on a treadmill at 5 miles an hour, 5.5 miles an hour? He experienced sudden cardiac death. The alarms went off. They did CPR. They defibrillated him. He died. The autopsy revealed atherosclerotic and hypertensive cardiovascular disease. And this will blow your mind. The weight of his heart on the autopsy was 490 grams. As you well know, we're talking normally 300, 310, 280, not 490 grams. So if I've learned anything in my 50 years, it's that vigorous, high-intensity exercise is a double-edged sword. I'm going to get to your answer very quickly. Is a double-edged sword. It both protects against, but it can also trigger acute cardiac events, especially in the habitually sedentary person. I've been doing stress testing for 50 years or so. I don't worry about the guy who says, my doc referred me here, I'm running 20 miles a week. That's not the guy who has a problem. It's the guy who's doing nothing. You put him on a treadmill and you take him up to heart rate of 180, 190, all hell can break loose. It's as simple as that. So recognize that point. Another point that many physicians and patients certainly don't realize is atherosclerosis is far more prevalent in younger people than people realize. Landmark study, oftentimes cited, Dr. Muratuzu, decent place called the Cleveland Clinic, Circulation 2001, looked using intravascular ultrasound at the Cleveland Clinic, came to the sobering realization that in people, 85% or more of people over the age of 50 have atherosclerosis. If you grew up on the American diet, pressing the garage door button for it to go up, and so on and so forth. Recent Swedish study, large numbers of people, all asymptomatic, 50 to 64, large thousands, showed that 40 to 50% had underlying heart disease in the 50 to. So chances are, if they're over 50, there's a good chance they've got underlying atherosclerosis. So to get to your question then, the take-home message is regardless of age, if somebody's inactive, they shouldn't start high-intensity interval training or start running, even though they ran maybe 30, 40 years ago. I tell them in the interim, you've developed atherosclerosis. So you can't start running necessarily. You can get myocardial ischemia, malignant ventricular arrhythmias, etc. Have them gradually increase that walking speed from 2 to 2.4 to 2.6 and so on and so forth over time, provided they experience no symptoms. And I love my good friend Paul Thompson, who's a cardiologist at Hartford Hospital, says if you get pain or discomfort from your belly button on up that comes on with exercise, it goes away, that's very possibly an anginal symptom. It's not always substernal pain. It can be jaw pain, back pain, and so on and so forth. So provided no symptoms and that the rating of perceived exertion, I tell patients, should be in the 11 to 13 range, which corresponds to fairly light to somewhat hard work. Shouldn't be hard. Then gradually pick up the pace. You're less likely to develop a cardiovascular event using that methodology as opposed to training high intensity day one. It's a long explanation.
No, this is very helpful. And in really, so if we would summarize how we guide individuals, men and women who are trying to move from light to more vigorous activities without with the essence of avoiding injuries, avoiding harm, and also continuing to encourage them. How would you simplify the message for individuals who are, you told them to start first light, and then how do they increase the intensity of that?
In general, you want to start, first of all, almost any walking speed is 2 METs. Almost even a mile an hour is almost 2 METs. So anywhere between a mile, 2 miles an hour, and then gradually increase the intensity very slowly. So you're getting up to 3 miles an hour, which gets you over that for many people, gets them over the threshold of moderate intensity exercise. There's great evidence. The greatest benefits occur by exercising at a moderate to vigorous exercise intensity. But don't start with vigorous, which is 6, 7, 8 METs and so on and so forth. Once again, use your perceived exertion. Be honest. My own experience is that women tend to be far more honest than men. I've had guys on the treadmill literally falling off, sweating, hardly can talk. How are you rating it? Oh, it's 13, somewhat hard or fairly light. Got to be honest. Take into account breathing, general fatigue, leg fatigue. You really want an honest 11 to 13 throughout that. And as you get in better shape, you're going to get a conditioning bradycardia. Heart rate's going to get lower, so you can do more work. Instead of 2 miles an hour, getting heart rate of 110 or 120, you can ultimately work at 3 miles an hour with the same 110, 120 at the same or lower perceived exertion. So that's the best way to do it. And if people have any questions, I generally tell them, go to a place where, go to a local hospital or clinic where there are personnel who can help guide you along those ways. We've been involved in cardiac rehab here at Corewell Health, William Beaumont University Hospital for 40 years. We have people coming into us who've had a bypass surgery, heart attack, angioplasty, or combinations thereof. We'll start those people using ECG telemetry monitoring. We've got nurse clinicians, ACSM prepared exercise physiologists, and a cardiologist in the office almost all the time in case of emergencies. So as a result, people who are worried about their health and to start more gradually, and they've got medical supervision, and the nurse, if she sees a couplet or triplet or something along, she can say, oh, okay, take that speed down, and so on and so forth. So many patients say to me, just having the medical supervision soon after my heart attack has been very, very helpful. I know the Mayo Clinic, many other places have a cardiac rehab program, and strongly recommend that primary care docs, internal medicine docs, cardiologists refer their patients to at least 4 to 6 weeks of exercise-based rehab. I can't tell you guys the number of times we found somebody's in heart failure, atrial fibrillation, things that we convey to the referring physician that improves medical management. So for all those reasons, that gradually takes people up.
Yeah, I love this message. Starting low, go slow, and work your way up. Yeah, and I've also seen it not only for cardiovascular, but just like musculoskeletal stretching before people work out. People just want to come in like a weekend warrior. They haven't stretched and they pull something and they're out, for a while. So they get, they have to, same message there. But this segues beautifully.
Gabe, I agree with you 100%. And stretching is very, very important. But I also tell people the best exercise for any activity is that activity only at lower intensity. So if a cardiac patient says to me, my training range, I walk on the treadmill 3.2 miles an hour, I'll say do the stretching, but then don't turn the treadmill on at 3.2 miles an hour. Turn the treadmill on at 2 miles an hour, a little over, gradually increase that heart rate. And when you're all done, allow the heart rate to come down before stepping off.
That's fantastic. Yeah, and this segues beautifully into the next question, Dr. Franklin. So from your extensive expertise in cardiac rehab, you've shown that heart disease survivors, consistent activity extends life. If you had to translate that science of exercise meets longevity into an elevator pitch for families and patients, what would it sound like?
Well, I've been studying this topic for almost 50 years. So what I'll try to do is summarize in 50 seconds, Dave, this elevator pitch. Ready, go. Available data, including really good studies, which we call randomized controlled trials, strongly substantiate the profound and favorable impact that moderate to vigorous physical activity and improved levels of cardiorespiratory fitness expressed as METs have on 1, improving survival, 2, surgical and hospital-related outcomes. Patient goes in fit for a surgery, he or she is more likely to come out without prolonged problems. Number 3, reducing healthcare costs. The latest research says every 1 MET fitness level that's higher, you reduce healthcare costs for the year by $1,600. Fourthly, combating cardiovascular disease, heart failure, cancer, COVID, dementia, diabetes, stroke, and the otherwise inexorable aging process. I'll share with you too, many of your listeners may not be aware of the fact we talk about diabetes. Almost everybody, many people on statins. The latest research suggests if you're on a statin, specifically a high-intensity statin, you're more likely to develop diabetes. How do you counter that? Lose weight and improve your fitness. Peter Kokinos has a paper coming out very shortly in the Mayo Clinic proceedings showing exactly that. High-intensity statins increases the likelihood of diabetes, but exercise, fitness, and weight loss helps it. Lastly, prescriptive pearls, I'll say it again, the initial goal for all of our patients should be a fitness level over 5 METs. 5 METs, once again, 1.7 miles an hour, 10% grade for 3 minutes on the Bruce treadmill protocol. You got above a 5 MET capacity. And the other thing that I'd emphasize is Short bouts of exercise, even 1 minute, repeated throughout the day, confer significant health benefits. The analogy I give patients is, and you guys will laugh at this one, you don't have to put the dollar bill in the piggy bank all at one time. You can put 4 quarters in, or 10 dimes, or for my heart failure patients, 20 nickels, a few minutes here, repeated throughout the day. Everything I just said is captured in a review we did that I'll promote. It was published in Mayo Clinic 2023, titled Physical Activity and Fitness as Modulators of Health Outcomes. And for those who are looking for a simpler read, we published something earlier this year called How Much Exercise is Enough. The publisher was Healthy Learning in California, Monterey, California. You can go to Healthy Learning, their website. You can find that How Much Exercise is Enough booklet. So those are two good sources of this capsule view. I think I'm over 53 seconds now. So
I think this is the elevator pitch that everyone would stay in the elevator to listen to. So
Yeah.
So Barry, we received questions about exercise in relation to special populations, some specific populations. When it comes to exercise, which population subsets are at the highest risk for an exertion related to cardiac event?
Yeah, I think the key thing is exercise in itself is not bad, but exercise, especially unaccustomed exercise, unaccustomed, not mild to moderate, but unaccustomed, vigorous to high intensity exercise in people with underlying structural heart disease, for example, hypertrophic cardiomyopathy or coronary atherosclerosis, leads to a huge transient increase in the risk of acute coronary events. My friend Murray Middleman at Harvard showed in people who are sedentary with known heart disease who do vigorous exercise, their relative risk of a cardiac event may increase more than 100-fold. So that's critically important. I think the other thing I would emphasize in this response is age is also important. When I read a high school kid died suddenly during his track and field practice, more often than not, there's an underlying structural cardiovascular abnormality, most notably hypertrophic cardiomyopathy, that wasn't detected, a big enlarged heart that doesn't respond well to high-intensity exercise. For older guys like me over the age of 35, when there's a problem, almost invariably, it's atherosclerotic cardiovascular disease. Major study in marathon runners showed over a 10-year period, the average age of cardiac arrest was 44 years of age. So these are 42 to 44. So these are relatively young guys, most of whom had underlying coronary disease. That's the bad news. The good news is you guys can detect atherosclerotic cardiovascular disease. Oftentimes with simple treadmill testing or other testing, you can detect structural cardiovascular abnormalities with an echocardiogram. So those are things that I want to emphasize. These abnormalities oftentimes can be reliably detected by the right medical professional.
So screening for pre-existing condition is important. And we often say even for healthy individuals, it's important to look into your heart rate, look into your blood pressure, all of these simple measures that also can help guide the individual in knowing what are their potential risks. So when we talk about high risk activities, what are some specific high risk activities that you caution about?
First and foremost, I'd say shoveling, snow shoveling, heavy wet snow shoveling. The arm work, the Valsalva maneuver, the isometric straining, the cold temperatures, which increase blood pressure, constricting the arterioles, constrict those coronary arteries, which I tell my patients, these aren't garden hoses. These are like cooked spaghetti, your coronary artery, awful darn small. And then finally, standing still. When you're on my treadmill, you're walking, you're promoting venous return. When you're out shoveling, oftentimes you're largely standing still. So blood pools in the lower extremities. That impairs blood flow coming back to the heart. As George Clooney would say, it's a perfect storm. So every year, as you guys well know, you get heart attacks, fatal and non-fatal, with older people with underlying atherosclerosis doing snow shoveling. So I tell virtually all of our cardiac patients, you ought to get somebody else to do it. They sometimes say, well, I got a snowblower. It's not a problem. We have heart attacks coming in every year and guys using the snowblower as well. We did a major study, 36 sudden deaths, 4 were using a snowblower at the time. So it does reduce the risk, but it's not without risk. Secondly, competitive racket sports. I met a guy and we were chatting. I thought he was 50, 52. I look a month later, he's in the obituary column in our local paper. And I'm saying, how in the world can this healthy looking 50, 52-year? So I'm reading the obituary on this guy I met just one time. And it said he died during a competitive racquetball competition, so to speak. So he probably had underlying coronary disease over the age of 50. And he was in the competitive racquetball and died. The other thing we see, at least in Michigan, is every year there are heart attacks. And we've done research on this, heart attacks during deer hunting. The cold, some of these guys are inactive. They're wearing heavy clothes. They're going outside. We did a study we published years ago in the American Journal of Cardiology with a deer hunter who simply saw deer in front of him. And his heart rate went from 70 to 155. Okay, it's like a maximal stress test. Just the hyperadrenergic of seeing a deer and raising your gun. So for all those reasons, those are probably the most risky types of activity. The one on snow shoveling we published, if you go to the Mayo Clinic earlier this year in March, Dr. Nath, the editor, was so nice to agree to publish an editorial on everything we've learned about the hazards of snow removal. So that's in this year's Mayo Clinic, March, I think.
Okay. Well, these are really important things. I mean, some of these wouldn't even cross the mind of people, probably, especially my friends who are in Minnesota or New York, or we're used to shoveling snow, but we wouldn't think about it. So what you're saying is, it's important to make sure that you are prepared for it, understand the risks, and if you have risk factors or prior events, it's an additional concern for individuals to be cautioned about that and really mitigate the risks.
Yeah, I agree with everything you said. The only other thing I would add, and you may say this is controversial, if for somebody says to me, I'm not going to listen to you, I'm going to go ahead and do it. My answer is, you better get a top-of-the-line snow shovel. And he said, what's a top-of-the-line snow shovel? I said, one equipped with defibrillation pads, because your wife or your children may have to resuscitate you. The other thing I'll mention sometimes is then if you're not going to listen to me, talk to your cardiologist, maybe doubling up your beta blocker that day to keep some brakes on your heart instead of your heart getting up to 160, 170, 180.
Yeah. So after decades of work, you've seen countless trends come and go. What are 3 exercise myths you wish the public and clinicians would finally retire? And
Dave, can I give you 4 real quickly?
Yeah.
One I've touched on. For weight loss, when doctors recommend weight loss, don't go to the tables and say you need to lose 150 pounds. That discourages the heck out of patients. Recognize that a 5% weight loss, 300 pound getting down to 285, improvement in glucose, improvement in lipids, and so on and so forth. That's the first step. The point I make to clinicians is overcome inertia. Have them take action in something that they can do to begin to increase momentum. Secondly, the notion that some patients have, marathon runners are immune to coronary artery disease. This all started with a guy, primary care doc by the name of Thomas Bassler, published Physician in Sports Medicine, 1975. The key thing is 1976, 77, 78, 79, a good friend of mine by the name of Tim Noakes, world-renowned, Cape Town, South Africa, published a case report of 4 marathon runners who had unequivocal atherosclerotic cardiovascular disease. So the point I'm making is you can may be able to run a marathon, but you can still have significant coronary atherosclerosis. The paper I oftentimes cite is a handler in JAMA. Patient came in to his primary care doc and said, I ran a marathon last week, and first time ever, I had some chest pain. And the doctor's, wait, you ran a marathon. You're probably in good shape. He said, no, I think I had some chest pain. So they went ahead and did a stress test. Showed ischemic ST segment depression, in the lateral precordial leads. They reluctantly, this is 30 years ago, went ahead and did a cardiac catheterization. He had a 95 to 99% LAD lesion. So just because somebody runs a marathon doesn't mean they can't be immune or have coronary artery disease. So the point I want to make is that those at the extremes of exercise probably can reduce their regimens to more moderate levels, decrease the risk of cardiac events, and still get very substantial cardiovascular benefits. You don't have to run marathons or participate in triathlons to be healthy through exercise. Third one, spot reduction. People say, well, if you do this exercise, you're going to reduce the fat stores around your waist. That's not necessarily true. Great study, Annals of Internal Medicine years ago, looked at tennis players. Now, if anybody's going to have lower fat, it's on the fat for the tennis arm versus the other arm. The hypothesis was the tennis arm's not going to have the fat was identical. There was more muscle hypertrophy in the playing arm, but not any lower levels of fat. I had good friends 30 years ago, Frank and Vic Catch, had people do 4,000 to 5,000 sit-ups in a month. And they looked at body fat in 3 different areas. Fat in all 3 areas decreased, not specifically over the stomach area. And finally, number 4, I've had doctors tell me this, and I strongly disagree. Weight or resistance training does little, they tell me, to improve cardiovascular function or risk factors. Resistance training. Resistance training, in my opinion, is a great complement to an aerobic training program. So that notion is wrong. We have data today that resistance training improves both traditional and non-traditional risk factors. It also improves cardiovascular function. The simplest way I could explain this is if you go to lift a weight, let's say it's a lightweight, 5 pounds, but your maximum capacity is 10 pounds. That represents 50% of your maximal voluntary contraction, and you're going to get a fairly high heart rate and blood pressure response to lifting that 5 pounds. If I can improve that patient's strength, so 6 months later, he can lift 20 pounds, and he goes to lift 5 pounds, that's 25% of his MVC. You're going to get a lower heart rate, lower blood pressure, lower rate pressure product, lower chance of inducing myocardial ischemia or plaque rupture. So when lifting or carrying objects, people who do weight training have lower cardiac demands. The paper that I would refer your listeners to was published in Circulation. I was a co-author, but the lead author, Amanda Pollock, Paluch, Circulation last year, an update in the role of resistance training in health and disease. She did a beautiful job. I think she's at the University of Massachusetts. That was published in the flagship journal of the AHA, Circulation.
Amazing golden nuggets of advice. This is great.
As you were talking about these, Barry, I'm also concerned about people who often get dismissed for their symptoms. And those can be, for example, women historically struggled with underdiagnosed symptoms. So can you speak a little bit about even just the patient profile and individuals who can come when they are assessed for exercise and cardiac risk and exercise intensity? What observations have you seen from your own practice and what the research says about that?
First of all, I would be the first to admit that our ability to detect disease with all the tools we have even today remains imperfect. There are times, to give you an example of, I remember 20 years ago, I was regularly doing stress tests in a physician's office under the supervision of a physician. And I remember doing a test, telling a guy everything looked good, no problem. And 3 months later, he's knocking on my door. He says, "Remember me?" And I said, "Geez, you look familiar." He said, "You did a stress test on me 6 months ago. You said everything was fine." And I said, "Yeah." He goes, "I was just hospitalized this weekend in your hospital for a minor heart attack. How do you explain that?" I explained it from the standpoint that stress tests can pick up ischemia, but they're imperfect in terms of diagnosing who's going to have a heart attack. Stress tests, as you probably well know, are pretty good at picking up a 75, 85, 90% lesion, because those oftentimes manifest as myocardial ischemia with ST segment depression, angina, cardiolite or thallium perfusion abnormalities. Stress tests are not good at picking up a 40 or 50% lesion, and oftentimes it's the 40, 50, 60% vulnerable lesion, thin fibrous cap, large lipid core that ruptures suddenly and causes acute MI. So recognize that our ability is imperfect, and I try now. You learn for your lesson. Say this is not a perfect test. It's going to give us some idea right now. Does your EKG show any signs of ischemia called ST segment depression? Do you get any chest pain? And please be honest with it. Do you get any threatening heart rhythm irregularities? Frequent premature ventricular contraction. And when you get 3, 4, 5 in a row, that indicates extreme irritability. It's a reason actually to stop a stress test. So those are the kinds of things I enjoy teaching. I also enjoy teaching. I have patients who say to me, Doc, I had a 95% lesion and a 50% blockage in a different coronary artery. My doc fixed the 95. Why didn't he fix the 50%? And I show them a picture showing if you got a 50% blockage, you're still getting 90, 95, almost 100% of normal blood flow. It's that relationship where as you go beyond 70%, 75% blood flow decreases. So we physicians need to do a better job of explaining what are the benefits and what are the limits. You're learning good things, but they're not perfect.
Well, we only scratched the surface with our conversations today. So Barry, as we are wrapping up, I want to kind of ask you some quick round robin, lighthearted questions. One exercise or movement that never fails to lift your mood, no matter how the day's going.
Regular walking. It's readily accessible. I don't need special shoes or regular walking. I have a treadmill at home that I use. You might say, what program do you do on the treadmill? I shouldn't admit this, but I do the Bruce treadmill protocol up to a point where I finish at stage 3.4 miles an hour, 14% grade for 1 or 2 minutes, and that's it. I recently had a stress test and got into stage 4, and the stages I use are 5-6 minutes a stage instead of 3 minutes a stage. So my fitness is for a guy in his mid-70s, around 11 METs, which is really pretty good. I try to complement that with either light resistance training or some types of calisthenics where you're using your own body weight. So long answer for
No, this is helpful. If you could change one public policy today to help augment the value of movement and exercise in healthcare, what would that be?
It bothers me immensely when schools give up physical education. Well, we've got to teach French and Spanish and English and arithmetic and so on and so forth. I think kids in school sometimes develop long-standing habits, whether it's tennis, singles tennis, doubles tennis, and so on and so forth. So I think getting people physically active and maintaining that goes a long way in terms of combating our number one killer, which is atherosclerotic cardiovascular disease.
Starting early. Is also important.
Yeah. We call it primordial prevention. I tell this is primordial prevention versus adults, primary prevention versus the people I see, secondary prevention. You want to try to prevent risk factors in kids before they emerge.
Creating a culture of activity. A holiday or weekend ritual that reminds you that joy counts as movement as well.
Holiday or weekend ritual. One of the things that a lot of people that I know do is they get involved in 5Ks. It's not running a whole marathon. It's a mini marathon, and people will walk. They feel exhilarated. They feel like they're physically active. That's far more realistic than the 26 miles that people take. I think just going out for a 30-minute walk with your spouse or a friend goes a long way in terms of reducing stress. I'm not thinking about all the stuff I got to do if I'm out for a walk. I'm carrying on a conversation with a friend or family member. My wife and I, when better weather, have a 3 to 4 mile course that we do on a regular basis.
One book you would recommend for anyone that is interested in reading about exercise and movement?
Probably, I mean, I'm going to promote my own book because it was just published this year. It covers almost everything I said here is in this little booklet. I think it's $12 or something like that. It's a booklet, Healthy Learning, Monterey, California. And I was fortunate enough to approach our hospital, and I went to the foundation, and I knew the president of the foundation, and I said, we need a booklet. Well, it's not something $30 or $40, $10, $12. And they gave us a $8,000 grant, which basically paid for that. The first people that got it were our patients in cardiac rehab and other disciplines. So our patients benefited from it. And now people all over the country are ordering the booklet. So
wonderful. Since you brought up cardiac rehab again, I really want to make sure that people understand the value and the benefit of cardiac rehab, because as we're in healthcare, and we understand that it is such a crucial, significant, impactful, and effective method to support patients who are coming out of, be it cardiac rehab or pulmonary rehab, coming out of events or conditions, but it remains one of the most underutilized services, and maybe just if you can just provide a little bit of a public service direction and guidance here.
No, I agree so much with you. In fact, there was a paper in JACC a few years ago comparing cardiac rehab with aspirin, statins, beta blockers, Plavix, clopidogrel. All those other things were 80 to 90%, 95% versus cardiac rehab, which was hovered around 60%. That's unfortunate. People can enroll in a cardiac rehab program, and usually they range from 6 to 12 weeks maximum, 2 or 3 days a week. You're under generally nurse supervision, exercise physiologists who really know about meds and exercise prescription. Oftentimes there's a physician immediately available. I've been here, knock on wood, 40 years, never a death in the cardiac rehab program. Yes, we've had episodes of hypotension and hypoglycemia and malignant arrhythmias that were reversed, and so on and so forth. But I think it gives people the confidence that here you've got medical professionals, coronary care unit nurses watching you. We have a very strong allied physician who support the program with large numbers of referrals. My job has been to do a medical grand rounds once or twice a year. If a new paper comes out on the benefits of cardiac rehab, our front office staff will send a copy of that to every one of our referring physicians. Little things like this go a long way. For physicians who are worried about losing control of their patients, we make it very clear we work for you, the referring physician. We have the time to spend in risk factor modification, medical surveillance. We can enhance your practice. Physicians have come to the sobering realization that by referring their patients to cardiac rehab, they're getting added surveillance. I'll call and say, Dr. Trevax, your patient came in and said his heart rate's irregular. We just did a quick look, 12-lead ECG. He's in atrial fib. I want to see him this afternoon. We'll get him on Eliquis. Little things like that. Sometimes people say, oh, that's just like the YMCA. There's more than that. There's medical surveillance. There's counseling. There's explaining things to patients. And we can do that. And it's covered by almost all insurances. And people should enroll in that. And the latest studies suggest it reduces mortality by somewhere between 20 and 44%. That's a big dosage. So,
well, Barry, thank you so much for spending time with us today and reminding us that movement is more than activity, whether it's state-of-the-art cardiac rehab or everyday living. Your work and your research really shows how exercise is prevention, purpose, and healthy longevity. And it is medicine, measurement, and meaning all together in motion. So we appreciate you spending time with us today.
Well, kudos to both of you guys. I do a lot of these, and I've enjoyed this as much or more than anything I've ever done. The interaction was great, and I can't believe almost an hour has flown by. So, okay.
Thank you. Thank you. We
Yeah.
appreciate you. Well, for our listeners and audience, explore Dr. Barry Franklin's recent publications and work and programs that bring exercise into care in new and practical, simplified ways. Whether on his personal website, go to www.drbarryfranklin.com, or through his academic endeavors and work. So thank you for joining us.
Moain, Dave, thanks so much for your time. Appreciate it.
And to all our listeners out there, until next time, inward with courage and outward with compassion. Thank you all for listening in.
Thank you for joining the Well-Being Manifesto podcast. Be sure to subscribe, like, and leave us a comment or review. To learn more about this discussion, visit thewellbeingmanifesto.com. And remember, inward with courage, outward with compassion.